Assalamu alaikum wa rahmatullahi wa barakatuh. Let's complete our presentation, and we will go to explain now the observational studies, the analytical part, which include comparison of two groups or more. From the analytical observational study, it can be a case control, which we call it retrospective, because it depends on the past events. Here we are in the present, and the investigator starts the study to define some cases and controls. The cases have the disease, and the controls, they don't have the disease or the health outcome. Once he specifies his cases and control, then he can ask them about past events, either personally through a survey or by reviewing their medical literature, their medical records and their health data. The purpose of reviewing the data is to determine the exposure in the cases and the controls. So we can draw conclusions between presence of the case and some exposure. In the case control, is good to assess a specific exposure in cases compared to controls. So you can study many exposures and specific outcome. It is inexpensive and happened in a short time. Now, of course, nothing in medical research finished in short time, but compared to cohort studies or RCTs, case control considered to finish in a short time relatively, especially if the data are available. Case control suitable for rare diseases because we don't have to have a very big sample size. We want to have a few cases and few controls of the disease. And it is good for causal factors of the outbreak. Now, in outbreaks, you need to get very fast information about the exposure of the outbreak or the causes of the outbreak. That's why in outbreak, one of the first studies conducted that give us a reliable information are case control studies, especially when the outbreak is in the beginning, as happens in Corona time. In case control, matching of the cases and controls increased the validity and the quality of the study. And matching mean we take similar population in cases and controls in terms of the confounding factors. For example, if we are studying cardiovascular disease, we might take the cases. We know that gender is a confounder in cardiovascular disease because it occurs in males more than females. So if I want to balance this confounder, I want to take from the cases more males and fewer females, or I may take 50-50. The same percentage that I take in the cases, I try to make similar percentage in the controls. By matching the confounding factors between cases and controls, you decrease the effect of the confounding factors, so you end up with a more accurate estimate. And our estimate in the case control is the odds ratio. So odds ratio, as we said, it is good for rare disease like cancer or outbreaks, infectious agents. However, case control holds some inherited disadvantages. First of all, if you take the cases, probably you mean the confirmed cases or the diagnosis. the diagnosed cases by medical decision. If you apply that, then you will miss the asymptomatic patient, right? Or you miss those patients who are in the processes of the diagnosis but not reach to the confirmed or full diagnosis. And this can affect also the overall picture between the relationship. Case control is holds the recall bias, because if you ask the patient about past event, they may overestimate or underestimate their exposure. In the cases, because they know they have the disease, they may overestimate the exposure, like in the corona time, when you ask someone who have been diagnosed with a positive PCR, he will count all the persons he have met during the last week, and he might think that they are all sick people, so he get the infection. So this is give you an overestimation of the exposure. While in control, they might underestimate the exposure because they don't feel it is serious or it is necessary to be reported because you don't have the disease. Case control also, in case control, there is a difficulty in identifying the controls. For example, if I take cardiovascular disease patients as cases, then who will be my controls? Are there healthy patients? They can be any individual who might have other chronic disease but not cardiovascular disease. They might be inpatient who are admitted to the hospital, but they don't have cardiovascular disease. They might have other, maybe respiratory or other infectious disease, but not cardiovascular disease. Which one to choose to be the controls? This will affect also the estimate of odds ratio and the overall relationship between the cases, between the outcome and the exposure. And it needs a lot of literature studies and comprehensive review about the how we assess the relationship and how we differentiate between cases and controls. But still, case control are one of the good designs in epidemiology of the medical field. This is an example of a case control. We want to study the association between lead exposure and ADHA in children. The cases are children with ADHA, while the controls are children without ADHA, and the exposure, whether they exposed to lead, yes or no. And here we estimate something called odds ratio, and the odds ratio is the odds of the outcome in exposed divided by the odds of the outcome in non-exposed group. It happens to be 4.2 here in this study. And it means that ADHA is 4 times higher among patients who are frequently exposed to lead compared to those who never been exposed to lead. In order to make a good interpretation for the odds ratio, you need to use this phrase, compared to illustrate the comparison that is made between your exposed group and non-exposed group. Another example for the case control Here we want to determine whether breastfeeding protects infants against pneumonia. The data were taken from Mother and Child Health Survey in Ireland and that was started at 1993. In the registry, the cases were babies admitted to a hospital for pneumonia in their age from 0 to 24 months, while the controls babies who were not admitted for pneumonia in this similar time frame of their age. And the exposure, whether they have been breastfed or not. In this study, the odds ratio was 0.6, which is less than 1. And it means that the breastfeeding is associated with a decreased risk of pneumonia by 40%. Why 40%? We took the reciprocal of 0.6. 1 minus 0.6 equals 0.4 divided by, 0.4 multiplied by 100 to get the percentage, which is 40%. So a 40% is the magnitude of decrease the risk when the exposure is present. And our exposure here is breastfeeding. I hope this interpretation of the odds ratio, which I made here, help you to understand the numbers that you see in literature, because sometimes the interpretation is not very clear. So if you understand the concept, then you can make your own interpretation. Let's move to cohort studies, which is prospective. Now we are going forward in time, in the future. We are in the present, and we choose cohort, which is a group of population that met the inclusion criteria, and we divide them based on exposure. Some of them have the exposure or exposed, and some of them, they are not exposed to the specific measurement of parameter or risk. Then we follow them up in a specific time until we measure the incidence of the disease in the exposed and non-exposed. And here, notice that I said incidence because we have a specific time frame and we can count every new case that is diagnosed with the disease during this time frame. So this is the correct definition of the incidence as we mentioned it early in the lecture. So this is a big advantage of a cohort study. It can give us the incidence. It is useful also to for study a range of outcome with a few exposure. So if we have a cohort, then we can study many outcomes, mortality or recurrence, progression, for example, in case of cancers, relapse, event-free survival, many outcomes that you can measure during the time of follow-up. It can establish causality because you started with a group that you know for sure that they don't have the outcome by the medical exam and the lab exam, you know for sure. So here you start with the correct consequence, temporal consequence of the events. You start with the cause and then follow up for the effect of these causes. Also, there is no recall bias because you are following the patient and they don't have to remember a lot about their past. Of course, cohort study with all these advantages have some disadvantages because usually it will require a large sample size, and this will cost resources, so it is expensive, and take longer time for the follow-up, especially when you are studying, for example, oncology patients or cardiovascular patients. You have to wait years until to get the outcome or the mortality or the progression or whatever a health outcome that you are waiting for. Cohort of these types might take tens of years. The other big disadvantage in the cohort studies are lost to follow up, because you start with a specific group of patients and you hope for them to continue with you until the end of study. But that's not what happened in reality, because people change their mind about enrolling in the study. They might move to another city, they might lose the contact. So some patient will be lost during this experiment or this follow-up. And this will affect the sample size that you started with. And the sample size is related to the power of the study. So if you have less sample size, then the power of the risk that you are estimating will be decreased also. This is an example of a cohort study. We want to assess the effect of smoking among pregnant women in low birth weight babies. Pregnant women took a baseline survey about their general health and some clinical measurements, then were followed up until delivery. The data then of the outcome were collected from the mother and the babies. And the risk ratio in the cohort studies were, in this cohort was 2.4. Our estimate here in cohort called risk ratio, risk of the outcome. In case control, it was odds ratio, just to remind you. So what is the interpretation of this 2.4? It means that smoking mothers have twofold probability of having low birth weight babies than or compared to non-smoking mothers. If I complete the sentence, I have to say compared to non-smoking mothers. And I may have rephrased this sentence. I may say smoking mothers have 2 times risk of having low birth weight babies compared to non-smoking mothers. Okay. Another type of cohort study is called retrospective cohort, or we might name it as historical cohort. The same conditions apply here as the typical cohort study. However, all data have been happened in the past, and the investigator tried to collect these data retrospectively. How we do this retrospective cohort? Well, first of all, it depends on the database. If you have a good database, then you can identify cohort from this database. And I mean by cohort that a target population that fills your research question and eligible for inclusion criteria. That means cohort. So if you identify cohort from this large database, then you can divide the cohort into exposed and non-exposed. Remember, this exposure happened in the past. So you just catch the cases who have the exposure and catch the cases who don't have the exposure, and then follow them up within the database until you measure the incidence of the exposure in both groups, the incidence of the disease in both groups. The advantage of this retrospective cohort that it is fast and it doesn't cost that much compared to other designs. It is suitable for analyzing multiple outcomes and rare disease, similar to the typical cohort. Measurements similar to the cohort in analyzing multiple outcomes, but similar to the case control in the point of rare disease. So it holds both advantages from cohort and case control. Also, that because the database. And here, measurements and follow-up already completed for you. So this is a big part of cohort study that have been done for you as a researcher, if you are lucky enough to have all the data completed. However, in retrospective cohort have many disadvantages. What happened in routine medical care, patients who were exposed to some health risk will be followed up more frequently than an exposed group. So you will find more visits, more doctor visits, more labs, more x-rays in the exposed group. On the other hand, you will not find similar frequency of lab on doctor visit in the non-exposed group, because these are the nature of the medical care. And this data were not collected for the purpose of the research. It was collected for other purposes. But you are trying to find, but you are trying to conduct research out of this existed data. So the existed data may not complete, and may not be designed as you want as a researcher. And the documentation might be very poor in some institutions. And also the loss to follow up will cause selection bias in this retrospective cohort. And selection bias also can affect, underestimate, or overestimate the relationship between exposure and outcome. So if you want to conduct a retrospective cohort and you want to take advantage of all these good things about this design, then review the database that you want to study. Review it and make sure that all measurements that you wanted to include it in your study are available and existed in the database before you start the study. Otherwise, it will be poor data, poor outcomes, and not very good research. Here is an example of retrospective cohort. They study the association between radiation from CT scan in childhood with brain tumors. The data were taken from the National Health Services Registry, and this is a very large registry. It includes hundreds of patients and running from tens of years ago. They identified children without previous cancer. So they started with the healthy children without previous cancer, but they have been exposed to CT scan. So there are information about the exposure of every child to the CT scan. And there is information also about whether they have been diagnosed with a brain tumor or not. So our exposure is there, our outcome is there in the database. We have good sample size, cases enough. So now we can go and conduct retrospective cohort, and that's what they did here. They follow the patients and estimated the incidence of brain tumors among each group. So they were able to estimate the incidence and the relative risk or risk ratio. happens to be 1.29. And what that means? Let's round this 29 into 30. It means that CT exposure increased the risk of brain tumor by 30% compared to no CT exposure in children. So we were able to estimate a risk from a cohort study without without suffering the follow-up and the waiting time for the outcome, thanks to the registries and the good database. That's why our health systems encourage making these registries for health outcomes, especially the important one that cost a lot in the medical field. Now, establish these registries in your field, in your specialty, will help future researchers to use the data and to conduct this important research to improve the overall knowledge. Okay. We reviewed observational studies until now. We talked about cross-sectional, case control, cohort, and retrospective cohort studies. Now let's move to the other part of the medical research, which is the experimental studies. It includes clinical trials and preventive trials. In clinical trial or preventive trials, we start today or in the present time and choose a population, a very specific population based on a very specific inclusion and exclusion criteria. And we randomize this target population to be allocated into 2 groups, or maybe 3 in some designs, either to be allocated to the experimental group or to the placebo group or the standard of care group. And the researcher then assigned the exposure. So he gave the experimental group the new medication, for example, while he gave the control group the standard of care or the placebo. Then he followed these 2 groups over time, specific time period for the follow-up, until he can measure the outcome in both exposed and controlled group, or experimental and controlled group. What are the advantages of the clinical trials? Of course, clinical trials typically used to evaluate the efficacy of a preventive or a therapeutic agent, because you have all the controls, you have the protocol, and you have assign an exposure or assign an intervention, and you follow up and monitor the progress of the disease with this intervention over time. So this full control of the researcher over the whole experiment increased the validity and the credibility and the reliability of the clinical trials. But also, randomization and blinding reduced the bias and the confounding. So even the bias and the confounding, we can control it in the RCT if it was designed very well. Randomization means that all individuals in the target population have the similar probability of being allocated in the experimental or in the control group. So you will not intervene as a researcher to allocate those patients. For example, a researcher might say, I know these patients will benefit more from our intervention, so I will put them in the experimental. But I know these other patients may not show us very evident effect, so I will put them in the control group. Randomization will cover this issue about the intervention and the bias from the researcher. By randomization, the researcher will not have the ability to choose which patient goes to experimental or the control group. Blinding also important. Blinding means that single blinding means that the participant did not know which medication or which arm he is in. Arm mean group. So if the participants did not know, he will act normally. But imagine in the case the participant, he knows that he is taking the new medication, while his friend in the other group, he's taking the standard of care medication, then this might affect his behavior to taking to take the medication, or he might want to switch, or he might want to discontinue the experiment. So blinding was made to cover these kinds of issues. Now, RCTs, although it is the gold standard of clinical research and efficacy research, but it is large and expensive, and also susceptible to loss to follow up, similar as cohort. Here also you start with a group of patients that you have been selected them very carefully, and you hope for them to continue with you until the end of experiment. But that's not what happened in reality. Some of them might lose to follow up or might not continue. So your sample might be affected, and this also will decrease the power of the study. This is the typical design for the RCTs. By the way, RCTs have many other designs. It may reach to 10 or 15 other design different than this typical one. Here we start with the subject meeting entry criteria. Then we apply randomization in this point to allocate some of them in the experimental and some of them in the control groups. Now the control groups might take different options, might take placebo, might take standard of care, might not take anything, depend on the situation and the research intervention. So we follow both groups until we reach the final catch of the outcome. Then we can estimate the risk of the outcome. Here is an example for a clinical trial. The researcher wants to test the performance of drug propranolol in recurrent myocardial infection and in decreasing the death rate. The sample was 91 males from 30 to 50 years to 53 years of age. They all had previous MI. The relative risk from this research was 0.3. 0.3 is less than 1, and it means that the intervention is protective or decrease the risk of the outcome. So this means that propranolol is associated with 30% decreased risk of recurrent myocardial infarction. And if you remember, in Corona time, all the clinical trials was conducted to study the efficacy of the vaccines were reported risk ratio less than 1, which means that the vaccine is associated with decreased risk of infection, or it is protective from the infection. That was all about original study design. Let's review the secondary study design, which is the systematic review. Systematic review and meta-analysis is the collection of many good research. It can be RCTs, it can be observational studies, based on the power of the study and the quality of the data, and the quality of the result and the validity of the results. So RCT is not limited to systematic reviews is not limited to RCTs. It can include also observational studies. The idea here is that we select a lot of studies that talk about similar research question, and we sift and collect studies. You see here, we take only the good one out of the collection of the studies. Then we extract data from the studies, we assess the quality, and we combine the data to make meta-analysis. Then we discuss and conclude overall finding. And this is the systematic review. Here we can disseminate as the pure extract of all the studies that investigated same research question. Why systematic reviews are important? Because it gives you the good estimate of overall studies and give you the whole picture of the studies investigated a specific research question. As we said, systematic review is a high-level overview of primary research on a particular research. It tries to identify, select, synthesize, and appraise all high-quality research evidence by critically appraise them, each one, that are relevant to the question in order to answer it. And this provide more reliable results upon which to draw conclusions and make decisions. Now, meta-analysis is a statistical analysis of a large collection of results from individual studies for purpose of integrating the findings. Pooling the data means higher power. So if you have many studies, then you can take their estimates and pull them up and collect the data. All of them, you will get larger sample size and more accurate estimate from all these studies, which we call pooled estimates. The results of well-done meta-analysis with a good quality RCTs could be considered as top source of evidence. But remember, meta-analysis is optional and is additive to the systematic review, but it is not necessary if the data are not available. Here is some recommendations. Designing Clinical Research is one of the best books I have ever read in designing clinical research. And here is BMG, a website to review the study design. And here is my contact. Thank you for SCAPE platform for inviting me to this event. And I hope that was useful for you. Please contact me if you have any questions. And goodbye.